Hello, everyone. We welcome you to the Stanford Healthcare Design Challenge Pitch Day, and we're going to get started. Okay, next slide. Okay, it's my honor to introduce our team. We've been working very hard for the past 5 to 6 months. Uh, First of all, we have Richa, who is one of the co-leads and one of the main people that has helped us put this event. Next is Ishan, who's he's one of the he's one of the main characters that have made this challenge possible. Next is Sherry. Guys, wave as I say your name. We have Sonia, Rifat, Maritha, Kelly, me, and Millie, Zainab. We have Kyle, Brian, and Brenda.
Recording in progress.
Okay, so the agenda for today is we're gonna be starting off with from welcoming everyone, making sure that you know who we are. We're gonna do the first half of the pitches at 9:10, so you still have like 8 more minutes to get ready. And then we're gonna have a break in between, uh, which is around 10:10, so in an hour. Next, we're gonna have the second half of the pitches. Uh, And then we're gonna spotlight our partners and sponsors and judges that have made this possible. Next, we're gonna be announcing the winners. So please stay the whole entire time. And we're gonna have some closing remarks. And yeah.
All right, perfect. Thanks everyone again for joining our session. It is the big day, it's the demo day. So to introduce a bit more about SHDC, Stanford Healthcare Design Challenge. As you know, only 7% of projects had any activity 6 months after a hackathon ended. And many of these high potential ideas, they will just die in utero due to a lack of resource and support for development beyond the event itself. And next slide, please. And we want to change this paradigm. We want to design an accessible and fully virtual challenge. And our main differentiation or our goal is to provide the post-competition support that lasts for 3 months, which offers funding and also advisory board for the winning team after the competition. We also want to try to democratize the knowledge through our September learning series, and also to expand our access and recruit many mentor networks, and also our amazing judges who are here with us today, as well as our partners to help these students develop the ideas. Next slide, please. To learn more about our organization, you can visit our website, which Bara has spent many time and effort putting together. It's an amazing website. And you can go to shdc.stanford.edu. Next slide, please. This is our inaugural cohort of SHDC from 2024. We had an amazing 12 teams and it was a great success. Next slide, please. In particular, I want to highlight and congratulate the ELA team, which stands for Education, Literacy, and Awareness, for their participation in Celestinus, a tech incubator program, as well as receiving the Most Creative Use of AI Award at InterSystems Ready 2025. Well done, team. Next slide, please. So what's next? For this year, we had a global vision for design challenge where any student from any university anywhere can join us in building the next generation of healthcare solutions. Next slide, please. This year, we've invited speakers from diverse backgrounds, expertise, and geographical locations, including venture capitalists, policymakers, entrepreneurs, physicians, and so on. Next slide, please. This year, we've invited, So our prompt this year is design a financially sustainable and scalable healthcare solution that addresses the healthcare needs of a population experiencing geographical transitions, specifically focus on the needs of a group of people experiencing either voluntary or involuntary migration within a domestic slash international internal or international context. Again, you can visit our website to see the full prompt, which I'm sure many of you are very familiar with already. Next, I'm going to pass it on to Richa.
Awesome. Next slide, please. Great. So our acceptance criteria for teams primarily focused on the teammates themselves and the problem area. It was super important for us that all of our teams and teammates are really passionate about the problem that they're trying to address and have spent time doing research on their subject, whether it's through the September Learning Series, interviewing customers, or anything else. Next slide. So this September, we received hundreds of applicants, in which we selected 45 students across the world to participate. We're also really grateful for the strong network of over 80 professionals who have helped mentor these teams, lectured in the September Learning Series, and are here today as judges. And we're excited to grow our reach every year. Quick plug to follow us on LinkedIn if you're not already doing so. Next slide. So as I mentioned earlier, the Global Challenge brought in teams from all around the world. Last year, applicants were all from the United States, so we're so thrilled to have innovators from different countries who bring new perspectives to healthcare innovation, especially when we're talking about our prompt related to migrant and displaced populations. Next slide. In addition to our September Learning Series, selected teams had access to our October programming to help them build in such a short period of time. Our challenge is only 2 weeks, so it's quite the grind. We got to hear from Craig Lindquist from the Clinical Excellence Research Center, who spoke about the hard transition from ideation to implementation. Michelle DeHaaf from Stanford Biodesign, who spoke about the need finding and biodesign process, and Shubha Chakravarthi from Achieve, who taught students about financial storytelling. And now I'll pass it on to Bharat to talk about our cohort.
Sorry about that. We had 11 teams this year, and the first one we had was Health First. Next was Vaccine Track. We had Lionheart, Health Guardian, Life Support, Life Passport, Operation Innovation, Masova, Maisha. We had Etho Health Tech, Amani, and K Bracelet team.
So this is the judging panel that we have this year. We're very excited to be able to attract such amazing, talented people to come give their thoughts on the students' ideas that we have. And we're excited to have different players in different fields to bring a variety of perspectives about all the relevant stakeholders to these solutions. Primarily, what we ask our judges to look at are the team's understanding of the problem, the solution value, the feasibility of implementation, overall presentation here at Pitch Day, and then product differentiation. And we're very excited to have all of these judges on board. During the deliberation process, we'll give a much more in-depth introduction to who the judges are. And then after the end of the deliberations, they'll come back and introduce the winners. So moving on to prizes, this year we're very excited to have Analog Devices as our flagship sponsor. And the prize money that we offer includes 2,000 US dollars for the grand prize winner, 1,000 for the runner-up. And then Analog Devices has a special use case prize that'll award $500 for the best team that apply or the team that best applies hardware, software, or hybrid tools to capture and process body signals, turning them into actionable insights for personalized value-based care. So we're very excited to have them on as a sponsor, and we're super grateful to all of our sponsors and partners without whom this challenge would not have been possible. So teams, I'm going to give you some very important instructions now. Please pay attention to what I'm telling you and then also what's on the slides. This will help us facilitate the presentation process and move smoothly from one team to the next. So this is our pitch order. Please make a note of the teams that are before you. And I would recommend, the team before you and the team before them, just make a note down of who those are, because when we go from one team to the next, during the transition period, we'll ask you to help facilitate that transition by being ready on deck and ready to present your slides. So the order we'll go in is Health First, VaxiTrack, K-Bracelets Team, Lionheart Health Alliance, Life Passport, and Operation Innovation. We'll then have a 10-minute break and then come back to present Mashova, Maisha Maternity Briefcase, Ethio Health Tech, Amani, and Health Guardianas. So here are some detailed instructions about how we're going to do this. Each team will get 5 minutes to do their pitch. This is what you all have been preparing for. And then we'll have 4 minutes of a Q&A session where our judges will have the ability to unmute themselves and ask questions of your team. And then we'll have a 1-minute transition time following that. This will offer an opportunity to have some wrap up for any remaining Q&A. If you're still saying something and you cross into that 1-minute margin, that's okay. But we ask that you remove your screen sharing so the next team that's up can get ready to present. The time will be shared on your screen as well as the SHDC screen. So let me show you what that looks like. Give me 1 second. Okay, actually, I think I cannot enable it while I'm still sharing my slides, but I'll show you what that looks like on the first team so we can demonstrate what that looks like. And again, when the previous team is going through the judge Q&A, the next team, please be ready to share your screen starting right at that 1-minute transition time. All right. And with that, we'll get ready to begin. Team 1, Health First.
Sorry, before we begin, I just wanted to confirm that all the judges have access to their judging form and the judging rubric. If you don't, can you let us know through direct message and I'll help sort that out. Okay, I think we can go ahead.
All right. And Team 1, please share your screen. Let me know if you have any issues with that.
Yes.
And actually, sorry, before you begin, let me just demonstrate what the timer looks like so everyone can see. Is everyone able to see this?
Yes.
Okay, perfect. So what this will look like is when we hit the end of this countdown, it'll make like a ding noise, and then that'll be the transition to that 4-minute Q&A session. Judges, please feel free once we hit the Q&A session, if the team is done presenting, to unmute yourself and begin asking questions. All right, and then I ask that only Team 1 currently have your microphones unmuted and your video on. Thank you. And it's okay if you're not able to turn your video on, that's okay.
Okay. Yeah. Yeah. Can you all see it? Okay.
Yes, perfect. You
Uh,
may begin.
Okay. So we're Team Health First, and yeah, we're Team Health First. Sorry, 1 second. Right. So imagine you're a factory worker from Bihar who moves every few months to Gujarat and then Delhi and then following work. Each move means new housing, new employer,
Sorry to
new
interrupt.
healthcare
Just
system.
we're not seeing your slides right now. We're just looking at the pitch. Yeah.
Yeah, you can wait. I think there's an error. That was just my notes section. What's going on? That was sorry. Is there a problem with the screen share or something?
No,
Because
we
I
can see
had
your
to.
screen. If you,
1 second.
We can just see your whole desktop, so maybe try unsharing
So
and
1
then
second. Yeah, those were my notes which I had enhanced. 1 second, there's some problem. How can I stop this? 1 second. I'm okay. This is a little messy. I didn't know how to do this. Can
it's
I
okay.
keep?
Just try
Sorry.
unsharing really quickly, and then when you
I
hit
don't know
share
how to
again.
unshare. I'm not very great. How
let
do
me
I do
stop
it?
your sharing. Okay, I have
Okay.
disabled your screen sharing.
Sorry, can I go next? I'm a little, I don't know how does this work and the timer's going off. I don't
Yeah,
know.
let
I was
me,
supposed to.
yeah, sorry, I just didn't see the timer. Yeah, we'll reset the timer. For sharing, when you begin sharing, and this applies to all our participants, this we should go through this. So when you share, you'll have an option to share the entire screen or specific application windows. Make sure you select adjust your pitch deck, so have that ready to go, and only share that so we can see just that.
So can you let me know if my entire screen, if
Yeah.
my one screen is getting shared, because those were my notes actually.
Yeah,
So
yeah. Go ahead and we'll let you know.
uh it's showing application windows to share. So I have to click either one
Yeah,
or
whichever
just
one is the pitch deck.
uh it's not showing that as an option apparently. It's showing only Google Drive, and then I have to I'm clicking this, but then apparently y'all are seeing all my slides, all the screen.
Okay. In
So I
that
don't know what is wrong with this.
okay. In that case, we're gonna have one of our team members walk you through it, and we'll move on to the next team, and we'll recircle back to you if that's all right.
Okay.
Okay.
Thank you. It's okay. Okay, yeah.
Okay. Team 2, are you ready on deck? I can.
So, sorry, I have the judging form, but I don't think it allows you to advance to the next one if you haven't filled out the one for the first team.
Okay. For the time being, I'll make a note of the sequence that we're going in. So that way, whatever you enter for the specific teams, it's okay. I have a note of what we're moving on to. Yeah. Thank you. Thanks for bearing with us, everyone. Okay. Team 2, are you ready? So this will be VaxiTrack.
Yes.
Okay. Please go ahead and share your screen and let me know if you have any difficulties with that.
Okay. Can you see my screen? Can you see my screen?
Yes,
Yes.
we can see it now. Thank you.
So I'm trying to switch on video.
Yeah. Okay.
I don't know. Let me check this in. So,
All right.
wait.
Are we ready? We'll get ready.
No,
Yeah.
hold
Okay.
on. Okay.
We see you.
Yeah, we can see you now.
Okay.
Yeah, screen
Thank you.
sharing is okay.
Hold on, I'm not ready yet. Okay. Yeah. Can you see my screen now?
Yes. Thank you.
Okay.
Okay. So I will begin the timer and you guys are ready to go.
Hmm?
Please begin.
Good day, everyone. I am Ashiru Mustafa, and I'm here to present our product, VaxiTrack, the intelligent vaccination for an unsettled world. Every 20 seconds, a child dies from a vaccine-preventable disease. Most of them never got a chance. And a woman dies every 2 minutes due to pregnancy or childbirth. This is a similar case of Aisha, a mother of twins, of Aminu and Amira, who lost her health card during the period of crisis and migration. Unfortunately, Aminu died, while Amira survived, but partially got blind. This is the reality of millions. The scope of the problem is enormous, with over 60 million people displaced globally who lack consistent access to maternal child health services. The immunization rate in refugee camps and migration zones dropped below 40%, and every children need about 17 vaccine types, with about 40 to 50 doses by the age of 5, but only 20% of displaced children complete them. And also 20 million, over 20 million missed doses over 20 million doses were missed annually, which shows a significant economic loss. This is the economic impact here. One measles outbreak alone cost about over $3 million in emergency response, and every missed vaccine is equivalent to $45 in wastage. Now, why are existing solutions not insufficient and not sufficient? One, for mothers and caregivers, for mothers, the paper-based vaccination cards are easily lost during migration. Two, for healthcare providers, health data is fragmented across regions and facilities. Three, for NGOs, monitoring and evaluation is nearly impossible with paper systems. Lastly, for government, weak data flow undermines data surveillance. With outbreaks are usually detected too late, creating a reactive instead of a proactive system. These are the need criteria. To satisfy our stakeholders, the solution we must provide must be low cost and scalable, offline functionality, data security and regulatory alignment, trust to verified healthcare integration, user simplicity, and high efficacy. This is why we are presenting to you our VaxiTrack, which is an AI-powered multilingual system that ensures vaccine and maternal care continuity for mothers on the move. Here are the features. One, personalized vaccination and antenatal reminders with SMS, voice, and WhatsApp. Two is multilingual text-to-speech in various languages. Three is digital immunization and maternal health history record. Four is offline first USSD for non-smartphone users. Vaccine credit rewards for compliance, and real-time health worker dashboard for follow-up. Here is the underlying technology of our product. It is robust and scalable with AI-powered, whose framework is based on modern web stack and integrated with health data with inclusive communication and lightweight and cross-border ready. Here is our prototype.
Hello, VaxiTrack. When is my baby's next vaccination? Hi, Amina. Your baby's next vaccine, pentavalent, is on Tuesday, October 8th. Oh, thank you. What's time? At 10 a.m. at the community clinic. I will surely remind you one day before. Oh, okay. What should I bring along? Please bring your baby card and clean water, and remember to feed your baby before coming. Thank you, VaxiTrack. You are doing great, Mama. Every vaccine keeps your baby stronger. But lest I forget, can I still take the vaccine if my baby has a cough? If your baby has only mild cough, yes. But if the fever is high, please see the nurse first. Would you like me to call the clinic? Yes, please. Okay, calling the nearest available community nurse now.
That is a sample of our prototype. This is why VaxiTrack is unique. It combines maternal and child healthcare, operates multilingually, uses behavioral incentives, and it synchronizes between healthcare workers and other NGOs. Here are our target users. The primary ones are the migrant mothers and displaced refugees. Secondly are the NGOs and ministries of health. This is our market size, which we are capitalizing on with over 70 million displaced people, with $40 billion spent annually on maternal and child health. This is our revenue stream, which is the NGO contract for data and monitoring tools, vendor commissions for vaccine credit, premium API, and white labeling licensing. This is our scalable. It is feasible because it has a working demo which we presented. It is technically scalable because it is compatible with multiple APIs. It is sustainable because the revenue is via NGO licensing, and it has a rapid pilot efficiency. This is our impact metrics. The 25% increment, a reduction in maternal appointment default, 20% increased immunization completion, 20% engagement retention, and improved trust in healthcare system with increased data visibility. Here are our partners. We have partnered with MyBelle, and our mentor Lucy is working on securing a potential partner with international organizations like UNICEF and Gavi. Here are my teams: project manager, product manager, software engineer, full stack developer, and UI UX designer. Thank you very much.
All right, judges, we have now started the Q&A session. Please feel free to unmute and ask any questions you have for our team.
Mustafa, hi, this is Archana from the Gates Foundation. Thank you for sharing the idea. Definitely a really important issue. My question is, every country, almost every state develops their own health infrastructure, technology infrastructure, surveillance. Now with AI, most countries are developing their own care tracking, multilingual platforms. How do you think, VaxiTrack would do as a standalone platform versus something that could be integrated within existing infrastructure in countries?
So I don't understand your question well.
Every country that does vaccinations has its own surveillance infrastructure and vaccine monitoring technology.
Okay.
Why would they purchase and pay for an independent standalone technology like VaxiTrack?
Well, we plan to actually partner with some kind of local pharmaceutical companies like and some other companies that deliver baby products and other baby diapers. So we are going to partner with them and to our vaccine credit, just like I mentioned. So once the mother use the platform, they actually get a kind of incentive which can be monetized in trading. So for instance, now when they go to these companies or a pharmacy to get baby diaper products, so the pharmacy or the company is going to offer them about 5 to 10% discount. So that is how we plan to sustain it independently, and we will get revenue in return.
Okay, what I just heard was a private sector channel approach, whereas your presentation focused on an NGO licensing approach. So that's just something for you to think about.
Thank you.
Gloria, I want to build on what Achana mentioned from Harvard University. So when I look at this new product, I'm thinking about both the desirability and the feasibility. It sounds like from your prototype, for the end user, for a mom, for a parent, it works kind of neat, right? The tracking system, the reminders, the voice dialogue is great. Yeah. But for your actual buyer procurement, let's say Gavi, right? What is a desirability factor? Like, why is your system superior to existing solutions out there? And also feasibility. You mentioned about AI-enabled dialogue tracking, and we know sometimes, AI could hallucinate, or the data security side of things, or the information accuracy may also be under scrutiny. So I just want to test a little bit more on these two dimensions. What do you think about it?
Okay, for the first part, the desirability of our product is that it combines maternal and child care continuity for mobile populations, which there is no actually much product like that in the market, and it also operates multilingually with behavioral incentives like vaccine credit, which other product does not have, and it has a strong synchronization between health workers and other telecommunications companies for disease surveillance. So for the second part, the AI hallucination, I think every artificial intelligence has the ability to hallucinate, but depending on like just like I said, we are actually like the underlying technology we used is based on modern stack technology with the front end and the back end parts, so which are very, very simple and easy to use. So the tendency for the AI to hallucinate is very low because the artificial intelligence we are using is not too complex. So making the ability to hallucinate very low. Thank you.
Thank you all. We'll move on to our next team now. Team K Bracelets, please share your screen and come start your video as well.
Quick question. So do we fill out the form on House First for this one?
Yes. So thank you for clarifying. So the form will have all of the names, but they will be incorrect. Just go with the order that we're going with the presentation. I've made a note of the actual order that we're going in, and I will correspond them in the form accordingly.
Thank you.
Okay, Team K bracelets, are you ready to share? If you're having any trouble, please message message me. And in the meantime, we'll move on to the third team. So, sorry, give me 1 second.
Next is
So,
Lionheart
yeah.
Health Alliance.
Lionheart
Yeah,
Health
that's
Alliance.
us. We can go right now.
Yeah,
Okay.
we're ready.
One moment, please.
All right. And you may begin.
Okay. Hi, everyone. We're Lionheart Health Alliance, compassionate care that speaks your language. My name is Damien, and I'm here along with Aaron and Kenta. We're graduate students from Loyola Marymount University's Healthcare Systems Engineering program with backgrounds spanning clinical care, community health, and process improvement. Together, we are Lionheart Health Alliance, California natives with immigrant roots who understand the barriers families face navigating care. Our shared mission is to build equitable, human-centered solutions that make healthcare access simpler, safer, and more connected.
And that mission is reflected in the experience of people like Leo, a 38-year-old cook from Guatemala with limited English proficiency living in Santa Ana, working hard to support his wife and 2 kids. After renewing his DACA status, he tried applying for Medi-Cal but was overwhelmed by complex forms and worried it might jeopardize his immigration status. He's one of 2.6 million Californians still uninsured. Half are immigrants just like him. And like so many others, Leo delays care, not because he doesn't want help, but because the system feels unreachable. So Leo needs something that makes healthcare feel simple, safe, and built for him. And to give him that, we need to bridge language gaps, rebuild trust that removes fear, simplify Medi-Cal enrollment, and connect clinics and communities so no family feels left behind. Our goal is to convert those changes into measurable impacts by reducing uninsured rates, raising Medi-Cal completion, cutting application time, and improving user comprehension. And that's where Simba comes in.
Imagine Leo again. He's sitting at his table after a long day at the restaurant with his son asleep in the next room. He heard from a friend about a new app called Simba, supporting immigrants in medical and benefit access. He scans a simple QR code on a flyer, and just like that, Simba opens right on his phone as a mobile-first web app. Right away, Simba obtains his preferred language from a drop-down of over 100 options. He picks Spanish and everything instantly switches, with clear audio narration to guide him. Simba's navigator helps him check eligibility and lists exactly what documents he needs. When he's confused by terms like restricted Medi-Cal, he taps the AI assistant, which answers in plain, friendly language or connects him to a trusted human navigator from organizations like CHIRLA or CareSen. He then gets a personalized action card with his clinic info, directions, and what to bring, all offline and private by design. And as policies change, Simba's live alerts keep Leo updated in real time. With Simba, healthcare finally feels clear, safe, and human.
This is Simba, a mobile toolkit that helps immigrant families get healthcare with clarity and trust. The navigator updates coverage as you move. Here we switch from Phoenix to Los Angeles and see the benefits.
When we looked at today's healthcare navigation tools, 2 stood out: Find Help and Castlight. Find Help connects general users to social programs, and Castlight serves insured employees. Neither meets immigrants where they are in language, in culture, or in trust. That's where Simba steps in. Simba speaks directly to the insured multilingual immigrant. It detects their language, guides them through Medi-Cal enrollment, and provides real-time help through an AI and human navigator hybrid. Where others list resources, Simba builds understanding, turning confusion into clarity and fear into confidence. It also bridges emotion and design. Our action cards simplify every healthcare step, while our privacy-first architecture reassures users who fear government systems. All user data is encrypted end-to-end and never shared with government or third-party systems, giving immigrants a rare space to seek care safely, confidently, and without fear. While other platforms list resources, Simba builds understanding and trust. And for people like Leo, that difference, turning uncertainty into confidence, isn't just innovation, it's impact.
Our early pilots will be funded by state and local health equity grants, with long-term sustainability driven by institutional partners rather than user fees. Health plans, counties, and CBOs will deploy the toolkit to meet language access mandates, reduce churn, and improve efficiency. We've already begun outreach, forming early connections with CBOs to ensure cultural alignment and trust. Targeting institutions keeps customer acquisition costs low, starting with Cal Optima Health, which already funds immigrant-focused programs and operates in a landscape where state and federal cuts to navigator funding have made scalable solutions increasingly necessary. Guided by mentor insight, community research, and customer discovery, Simba launches at a pivotal time amid Medi-Cal changes, funding reductions, and hospital strain. As outreach budgets shrink and eligibility rules shift, counties and health plans need scalable, multilingual tools to sustain enrollment and compliance. And as an emerging nonprofit, our mission is impact over income. Starting in the LA region, we aim to serve the 1.3 million uninsured immigrants across California through language concordant navigation, leveraging the $200+ million already invested in immigrant health access and digital equity.
In the next 3 months, our focus is clear: needs finding, partnerships, and funding. In our first month, we want to partner with CBOs to understand their challenges and co-design how Simba fits their outreach. Simultaneously, pursue health equity grants to fund development. In our second month, validate Simba with real immigrant users and CBO staff to ensure it's intuitive, trustworthy, and culturally aligned. And in our last month, integrate feedback, measure outcomes like enrollment success and navigator time saved, and prepare for a small-scale pilot to demonstrate impact. Our ask is simple: to join us in transforming trust into tangible change for the communities we serve. Because what drives us isn't just technology, it's people. When families like Leo can enroll and care confidently, we strengthen both community health and health system equity. Simba isn't just a toolkit, it's a bridge between mission and measurement, between compassion and sustainability. And we'd be honored to have your guidance in building that bridge. Thank you very much.
Thank you. And judges,
Thank
for Q&A now.
You mentioned, there actually was an existing partner that you're collaborating with a customer. I was wondering their interest and if they actually reviewed kind of your decks and ideas from that and any feedback.
Oh, sorry, are you asking about like the connections we've made so far and like the communication between? So we reached out like recently this past week, and we've heard from about like two or three. So we formed a line of connection, and one of them is asking for us to like send over our like one pagers and executive summaries, but they definitely demonstrate interest in our product and our technology. So we've kind of we have our foot in the door, but we are still waiting to kind of like establish a firm foundation and partnership with these communities. If that sort of answers your question.
Yes, thank you.
One
This is-
question for you, oh, sorry, should I go ahead? Okay, just a quick question. I mean, one thing for you to think about is how will you measure impact? It seems like it's right now the first point of access that you help a patient with potentially, but how do you follow them beyond that one transaction in the journey of their care seeking, if they need follow-up care and further connections to secondary, tertiary, etc.? Not sure how you're thinking about that.
Right. So I think a lot of what we have in mind for that is connections with community-based organizations. So a lot of our initial outreach has been to many organizations in the Southern California community that are already involved in these immigrant communities. That way we won't have to do a lot of the heavy lifting when it comes to making those outreach appointments and reconnecting with those individuals because they're already involved in those communities that we plan on connecting to. And through that, we hope to keep them involved and moving along with their care.
This is Jason Cunningham. Curious about the product itself. And by the way, good presentation. Is this a resource navigation or are you helping the patients complete the applications?
Yeah. Oh, Damien, go ahead.
Yeah, so we're actually thinking more of like a resource navigation type of thing where these our users would come to the app and be able to see, health forms translated for them so that they're able to reach these resources a little bit easier.
And then you would send them to the enrollment counselors at the community-based organizations to complete the forms?
So go ahead, Aaron.
Yeah, so it'll also act as basically like a eligibility screener to kind of like give them a good assumption as to whether or not they'll be able to like be eligible for Medi-Cal. And so, I mean, they're able to do that online or in person with like the community organizations. But our tool will help them guide them through those steps that they have to take, documents that they need, and information they need to present. So I hope that sort of answers your question.
Yep, thank you.
This is Gloria. I love that you have a sharp problem statement and helping that resource navigation for your target audience. My question is, you mentioned two competitors in the space, and that they deliver similar sort of products, but you have features like action cards, multilingual capability, which they don't have. What is the barrier? What is the barrier for them to copy some of these features, and why do you think you have a unique proposition?
So sorry, can you are you talking about like why like
Yeah, I see what you are saying is compared to your competitors, your value is building that trust, having that multilingual capabilities and these action cards and different features. What is a barrier for your competitors, the existing solution provider, to copy some of these features?
Kind of, if I may.
Yep.
I honestly, full transparency, I mean, there is no, I guess, specific barrier that's keeping them from doing this, but they themselves right now aren't doing that yet, and they've kind of already established themselves as what they are, and so we're something that is like newer, and we are grounding ourselves in culturally aligned like community organizations where we are grounding ourselves in trust to build trust with these immigrants so that they don't fear like, oh, if I apply for Medi-Cal, is my immigration status going to change? Like, we are really trying to ground ourselves in the community, especially as a nonprofit, to like help these individuals.
All right, thank you. And we will now have to move on. Thank you so much, Lionheart Health Alliance. We're going to circle back to our first team, Health First. And judges, so I know this is going to get a little complicated for you. So there are two options for the form. We can either have you continue doing it just in the sequence that we're doing the presentation, so ignoring what the titles are, or if you're able to switch over, you can actually put in placeholders for each of the entry boxes, and then you can move on to the next section, and you can come back to the previous sections. So whichever one works better for you, and just make a note in the text box at the bottom which team it's all of your feedback and the ratings are for, so that way we can keep them straight. And hopefully that is able to help. If you have any questions, please let me know as well. Okay, team Health First, are you ready to do your pitch?
Yep.
Okay, all right.
Ready.
Again.
I don't have permission to actually switch on my video, so my face, yeah, it's prohibiting me, unable to start video. Okay. So yeah, thank you. Okay, so this is Team Health First. We're Team Health First, and we've come up with a solution which is called the mobile integrated healthcare continuity system. And this is our whole idea. Richa, next slide. Yeah. So the problem what we're facing basically is that this is our big idea, okay? It's like we have our app, it's a mobile app. It has 3 key features, which works on Health Cloud Lite, which is a simple offline accessible health vault where workers keep, store, and carry their medical records with them. Even if they change, the continuity engine is like is like a smart system that leans patterns. And then it combines the appointments which are missed, it carry forwards the data, and it is reused, and there's backup store on the cloud, which has offline access. So all these 3 systems are synced together. The third system is Navigator Network. It is trusted. It's a trained community of health workers. Those health workers are migrant workers themselves. So the audience can relate to it. So the migrant workers can relate to it. So next slide. Next. The problem, here's what we found. Over 5,000 workers, when we did the pilot, 5,000 workers joined this concept. 85% said it made their healthcare easier and more accessible. The care gaps were meaning missed appointments and lost records, the data dropped by 40%. Our partners and NGOs, Seva and Prayas, as well as Project Mumbai, which has recently just been very interested. So they helped us, reached out and trained the local navigators to be a part of this project. So MICS is a three-part model. It is employer subscription and CSR partnerships and state integration. So these three make it self-sustaining and scalable. The vision is to expand from 5,000 to 10,000 workers, the partner with 3 more states, and build a national health continuity dashboard for policymakers and employers. With support of MIHCS from a Prove-It pilot and national-wide digital health layer, which is like a blueprint, is what we're trying to make it for healthcare, is like the health journey is never interrupted again. And then MIHCS is not an app. It is a movement to make health continuous, inclusive, and very mobile for every worker in India. So yeah, that is the thing. And we have a long presentation with a lot of slides and a lot of data which we've collected. So it's not possible to sync 20, a year of data into my presentation, but you all can always view the slides and the many, many layers. We've been working on this for like a year already. And we have tied up with Project Mumbai, which is building a layer between 2 NGOs, which we want to connect with. And yeah, this is about federal data and internal systems and all of that. So yes. So yeah.
Okay. If you're done with your presentation, we can continue with the Q&A and you'll
Richa, 1 second, just go to the slide, the last one, where there are testimonials. Yes. Yes, a little up. So this is our team. And these are the testimonials. So we got in touch with Shishir Joshi, which is the founder of Project Mumbai, and the Bhramar Mukherjee, who went to the Yale School of Public Health, and the MD of Morgan Stanley. And we reached out to these 3, and they're willing to help us in our mission. And this was what their idea was and what their opinions were about our concept. Yes, we're done. And any questions, please do let us know. We've not talked in detail, but I will be glad to answer questions.
Hi, Sachi. This is Archana from the Gates Foundation. I'm not sure
Yes.
I'm understanding what is the problem you're solving for.
So we are trying to build a continuity. We are not only trying to solve the migrant worker problem, the problem was continuity. So every time their whole data, we have a system of Aadhaar in India, which links our whole identity. It's just on a card. It's like a visa. It's a passport for every
I know
citizen.
Aadhaar, yes.
Yeah. Yes. So it's basically like that. So it's going to sync in all our files and all the details.
But all this already exists with ABDM and Health Locker in India. So what's the solution proposition here?
There is no. So the problem is the continuity. So a lot of medical records are lost, and a lot of people have problems with the system and interacting, and a lot of problems they're facing even with these systems. So we're trying to build a continuity system which helps them break down the language barriers. That is one problem which is not solved despite of the Aadhaar system. And the Aadhaar card, and not everybody has it. So we want to build a stronger system than that for healthcare in
That's
migrant
Ayushman
workers.
Bharat Digital Mission and Health Locker.
So this will be a plugin for it, because Ayushman Bharat does not have everything. So this app can also be used as a plugin with these layers, with the 3 layers which I explained. So that's there in the PPT. So it is also a plugin for these layers. Yeah. So it not only, it basically one problem which was not there in other apps, that the audience will not relate to them, because that's why we're hiring migrant workers itself to make it more relatable and make them navigate through the whole process. So that is one thing what we're trying to do, to cut down the language barriers by hiring migrant workers to solve the migrant worker problems in terms of healthcare. And we'll also have online support, which they can put up, which we will be putting up, and problems and guiding in detail, personalized on every account. So that will be an app supported with a web computer app, which is like a support system, which the per user cost will be very less. So that's how, by bulk.
Sachi, this is Pom from Stardex. I'm curious to hear, you said you already started some pilot projects. What have you seen as the biggest challenges in implementation so far?
Literacy rate. In India, the literacy rate is very, very low. So we've had a problem with that. And also language barriers, because in India, there's so many states and each state has its own language. The accent is different. It is so vast. It is absolutely crazy. So that is why the team which we have built of migrant workers, they will also be localized to areas and sub areas. Like if you look at Mumbai, for example, North Mumbai, South Mumbai, different areas of Mumbai will have different accents. And sometimes I can't understand the accent of somebody else living in like 10 miles of me. So that's how we're gonna be making it very concised and elaborate at the same time to overlap that. And yeah, and our vision is that India, I think, is the most challenging place to have such a concept work. So if this works in India, it will not be hard to globalize it. And we have the largest population in this country by obvious reasons. So, right. So that was our experience. And people were very open to getting our help. I couldn't really explain in details, but we have the data collected. We've had interviews collected. All of this data is there on this presentation. It's about a year of work. I couldn't explain everything properly, but this PPT has all of it. So yes, we've had interviews, selections, everything for this. Yes.
All right.
Any other questions if anybody has them?
Okay, we'll now move on to the next team. So is Life Passport here and available?
I think they're still trying to log in. We can move to Operation Innovation if they're available.
Yeah, we'll just put up the slides. Okay, wonderful. Can everyone see?
I can see it. I don't know if anyone else can.
All right, thank you. And you guys are ready to go?
Yeah, so good morning, everyone. We are Team Operation Innovation from London, UK. So we are presenting our SHDC product, the Ward Talkie. So our product aims to bridge language gaps in healthcare. So before we go any further, I'd like to introduce the members of the team. So we are 3 final year medical students from Imperial College London. So my name is Anitha.
My name's Keetana.
And my name is Lakshmi. We'd also like to extend our sincere gratitude to our mentor, Professor Anne Merritt, and our Stanford liaison, Millie Wong. So as medical students in London, where migration rates are rising and interpreter use still remains low, we've seen firsthand how language and cultural barriers can impact patient care in busy A&E settings, leading to difficult and unsafe consultations. So why is this a problem? Well, patients struggle to fully explain their symptoms and then consequently leave without completely understanding their diagnoses or treatment plan. So how can we make communication safer, faster, and more inclusive? Well, that's where the Ward Talkie comes in.
So Ward Talkie is an AI-powered multilingual personalized interpretation tool, and it's designed specifically for people like us for clinical use. So unlike general purpose translators, it provides real-time speech-to-text and audio translation. So it provides context-aware medical visuals, and then it can be integrated within our patient electronic health records. So our goal is not only just to improve real-time communication, but it's also to improve patient health education.
So essentially, when the patient walks into the room, they can input a few quick details about themselves onto the software, including their age, their gender, key cultural considerations, and also answer a few questions about their health literacy. And then the walkie-talkie will instantly adapt to these features and personalize itself for the consultation. So now, when the doctor is explaining the patient's condition to them, it not only does it come up in the right language, but also displays visual cues and explains the condition or treatment to the patient in a way that the patient is able to understand.
So our technology is made for clinical environments. And what do we mean by this? That means that all the models are aligned to the UK GDPR rules, as well as being DTAC and DSPT standardised for the NHS.
So how does a walkie-talkie actually work? Our software runs on an edge device that captures speech from both the doctor and the patient. It will also use noise suppression to clean the audio before securely sending it to the cloud, where Azure Speech for Healthcare converts it to text. The system then translates and sends responses back as speech, text, or visual aids, and the consultation will be summarized as notes, which is perfect for the EHR.
So currently, language line and unofficially, Google Translate is used in ED departments. So whilst it offers a very good language coverage, it is still inconsistent, and especially with language line, it has a per minute, per word pricing model. And as you can imagine, it's quite unsustainable in high demand settings like the ED. So another software is Pocket Talk. So this is a platform that provides interpretation services, but it lacks personalization, which is key in empowering patient health education, which is what our focus is. So our device, the walkie-talkie, is unique that it seamlessly integrates summaries into our EHR records, increases patient-doctor interaction, and accuracy of records.
So currently, the Imperial Trust are spending close to £1 million per year for live translators. However, with our price of $250 per user per month, it would equate to 312 devices for the exact same expenditure, which is a very large amount of devices, I think you'll agree. So essentially, this makes our solution a lot more cost effective. Our primary customer will be the NHS, starting with Imperial College Healthcare Trust, where we already work and study. So being NHS medical students gives us a very unique advantage. We understand the challenges clinicians and ourselves face firsthand. We know the systems and we already have trusted relationships within the hospital. To reach teams, we'll run ward trials, demo and ED huddles, and also work with clinical champions.
So some of the partners we want to collaborate with firstly include Digital Health London, who will be key in integrating our software into current NHS platforms. We also want to reach out to Doctors of the World, who will help us represent the migrant community and give us consumer feedback. And finally, which we have already started doing, is working with other Imperial students to further develop this concept.
So our next steps focus on getting the software ready for the live trial. So in month 1, we'll reach out to EDs while designing both software. In month 3, we will test and develop the features of the product. And by month 5, we aim to trial the software in an emergency department for 6 weeks with 3 devices.
So looking forward, we plan to integrate it into existing NHS computers as an easy-to-use application. And beyond the hospitals, we also plan to expand to primary care and other NHS settings nationwide.
In the future, we would also like to develop some sort of a hardware device that will support our walkie-talkie application in an offline setting, so that those providing healthcare in remote areas can also benefit from the translation services.
Thank you so much for listening to us. We hope you enjoyed the presentation, and we hope that together we can help bridge language gaps in healthcare. We'd like to now open the floor to any questions you may have.
Thank you for the presentation. You mentioned that one of your key differentiations is personalization. Can you elaborate more on that?
So essentially, what we'd like to do is first create a questionnaire, which will screen for health literacy. I think we've got a few slides
at
the end.
Just...
which will have like an example of what the health questionnaire will look like. And based off of this, we will train our AI model while we do the ED huddles to kind of give an explanation to the patient and change the level of language that is used, which will better help the patient understand and empower them to make the right decisions.
I wonder whether you have thought about accessibility issues for people who have low vision or who are blind.
I think going forward, so I think this was something that we would look into. So at the moment, the visual cues will come up as the doctor explains something, but it can also be that the device itself might be able to speak, so it can help anyone essentially.
And I was interested to learn too about what would get integrated into the EHR.
Yes, so what we're hoping with our technology is that during the patient doctor consultation, it takes a summary of what was being said, especially the diagnosis that's been discussed, and then this will be integrated into their electronic health records, which we have a platform called Cerner. And on there, it will be uploaded of what was discussed, and any plan forward that was discussed with the patient. And this is so that the records reflect the fact that we've used AI in the consultation.
So would it also be a transcription and summary, and a
Yes.
visit summary? Yes.
Yes, yeah.
Exactly.
My question is about monitoring the information and the data that is given out to the patient. It sounds very promising for the end user, the patient. Is there mechanism either real time for the doctor or the nurses who are involved to see the information that is given, so they can, have that human connection and, correct information if there is any, deviation from the case, or if it's not real time, are there constant monitoring, right, by the healthcare workers or by your team after the fact, retrospectively?
Yeah, so we can, what we were planning on doing was creating a transcript right at the end of everything that was said. So the doctors can definitely look through that, or the nurses can look through that and just double check that everything said was correct. However, you do provide a very good point as well. Maybe it'd be good to have a split screen where the translation is in English, which the doctors can read while it's being spoken out in the patient's language as well.
All right, and if there are no other questions, we're going to, due to some technical difficulties with the team that's queued up next, we're going to take our 10-minute break now, and then we'll come back and finish up the rest of the presentations. Thank you all so much for bearing with us as we were navigating the few challenges, and we look forward to seeing you after the break. And as we come out of the break, we'll have Health Guardianas up next. So if you can queue up your slides and get ready to screen share.
We put the new order in the chat, like if we're going to revisit one we missed.
Yes, yeah, let me do that. And Health Guardianas, if you can start screen sharing.
Yes, thank you. Okay,
And
let me know when to start.
Yeah, and if all of our judges are back in the room, let me just make sure. All right, looks like we have approximately a quorum. All right, and we can go ahead and get started. Your 5-minute timer is up on the screen now.
Okay, hello everybody, we're Health Guardianas, and we are creating a digital bridge for the well-being of female refugees.
We are a team of 5 with diverse backgrounds ranging from engineering to biology. Recently, due to the humanitarian crisis in Venezuela, displaced Venezuelans have been seeking refuge in Colombia. Because of this, female Venezuelan refugees are at risk of facing gender-based violence and in search of work will often face sexual exploitation. Gender-based violence, which includes sexual harassment, increased by 71% against Venezuelan refugee women in Colombia within the years of 2018 and 2021, according to Amnesty International. This leaves survivors with long-lasting trauma and mental health issues.
But why isn't this issue being addressed? While there are resources available through organizations like HIAS Colombia and UNFPA, there isn't a unified and well-publicized directory of the resources available. And in the study, it was found that out of 21 health facilities, only 8 of them spread information about the resources they provide. There is also a lack of knowledge about the rights that immigrants have to receive care and protection, which results in a fear of reporting, with only 1 in 5 Venezuelan women feeling safe enough to report. And so, we have identified the need for increased awareness of sexual assault resources among Venezuelan women refugees in Colombia who are subjected to violence and sexual abuse. Our solution to this issue was to build a digital resource center in order to connect refugees with healthcare access as well as sources for education. We want to utilize a platform that was not only easy to use but had a familiar interface, so we decided to use WhatsApp. We would train a WhatsApp AI-powered chatbot with inquiries in non-formal Spanish and voice inputs through natural language processing, ensuring the user is able to interact comfortably with the chatbot. It would also be taking information in real time from shelters, clinics, and other organizations to update space and resource availability. And how can we implement our ideas? We plan to target female Venezuelan refugees in Colombian border cities like Cúcuta, one of the cities with more influx of Venezuelan refugees and more cases of abuse and gender-based violence.
In terms of competition, online resources are easily accessible to the public, but they often provide ambiguous and non-specific information for female refugees. In contrast, hotline services allow them to verbally communicate their issues, but there's a lack of encryption and record of resources sent, making it unsafe and unreliable for long-term usage. These limitations are addressed in our WhatsApp chatbot, which is trained to address the specific needs of sexually assaulted female refugees, WhatsApp secure encryption, and a digital record of messages. We plan to secure funding initially through grants like UNFPA and NGO partnerships. Once the solution becomes more established, we plan to get funding from local governments and hospitals to broaden the scope of our resources. Our WhatsApp chatbot is a low-cost, effective solution. This includes around $500 for the development of the chatbot and a monthly subscription that depends on the number of users and text messages sent.
So, for our partnership strategy, we're looking to collaborate with Project Hope, an organization that already has partnered with healthcare facilities that provide obstetric and gynecological care.
in addition to community-based workshops on prenatal care, gender-based violence, and naturalization pathways. This will allow us to connect with hospitals that are already providers of care for refugees without documentation. In addition, our project is aligned with Colombia's government mission of helping refugees integrate into Colombian society. Therefore, we aim to work with the Ministry of Health and Social Protection in Colombia. And for our milestones, during the first month, we are going to look deeper into the community needs by conducting listening sessions with clinic staff and women refugees to map out the current referral pathways, relevant issues, privacy concerns for digital tools, and the overall care experience. This will allow us to make our solution more impactful. During the second month, we plan to consolidate and test our WhatsApp solution so that it handles text and voice inputs. It will have an integrated location-based directory with shelters and clinics and have micro-modules that provide refugees with education about their rights. During the third month, we will share the prototype with partnered organizations for testing, and we will collect feedback from the NGO staff and other users on the accuracy of the service and on the service listings, the empathy, and the usability. The next steps will consist of refining the solution, marketing through strategies aligned with the NGOs, and preparing to scale. Thank you so much.
If you want to help refugees with us, join Health Guardianas. And thank you. Yeah.
And we can move on to the Q&A session if the presentation is done. Thank you.
Thank you for your presentation and outlining the problem, specific problems. So can you talk a little bit more about a sustainable business model and how you would engage in that?
I can yeah, Carla can take that question.
Wait, no, go ahead.
Okay, so initially we plan to partner with NGOs and nonprofits and applying for grants as well. And then basically what we want to do is we want to have an established sense of, okay, this is helping our users. We searched up some grants we can apply to as the ones showed on screen. And the goal of the grants is to show the proof of concept. Like, we can get this running, like people are actually using our platform, and this is beneficial to the users. The next stage would be partnering with local governments in order to, because local governments also want to help the Venezuelan refugees because a lot of them don't utilize the resources because they're too scared to look out for them. So partnering with local governments in order to help fund us for the next stage. And then we're looking for sponsorship companies who provide existing resources and want to get the resources out there and connect them to their target demographic. Thank you.
I have a question. It's more around user experience. So one product I've seen before, also for women who are in danger, and on their product, they actually have a button, like they could easily just switch to a neutral website. So like if they're in danger and someone else get access to their phone, they wouldn't know like, oh, they are actually looking at resources that might potentially like help them. They're doing outreach. So I'm wondering, like in your case, they might actually leave a record on WhatsApp that they're looking for help. And what if that information is, like the people who are assaulting them actually get access to that? What's the way for you to prevent that?
Yeah, so there are a couple of configurations that we can use with WhatsApp. There's an option for temporary chats that get deleted after a determined amount of time. And we could actually, through our first stage of hosting listening sessions with the women refugees, we could have their input and understand the problem better and understand how they would feel about having the temporary chats or using another platform instead. So essentially, we want to conduct these listening sessions to understand their experience better, so just what you were saying, and then be able to serve them.
Could you clarify the monthly subscription that you had specified? So I think you said $50 to $200 a month would be paid. Who exactly is paying that monthly subscription fee?
Yes, so that monthly subscription comes from the cost of the software that we would use, and there's a cost for each text sent. And the 200 monthly subscription would cover like over 700 texts, but we would not be charging the clinics for this. We would use the money from the grant opportunities that we apply to fund the first stage of the process, and then through our partnerships with local governments, then we would seek for them to be paying the monthly subscription of the charge for the use of the texts.
Thank you.
Yeah, and if there's any other questions, you can put them in the chat. These are some target hospitals that we've looked into in Cucuta, and then these are some outreach that we have done already. So we have already reached out to 5 NGOs, 3 clinics, and 2 shelters in Cucuta.
Thank you guys so much.
All right, thank you so much. And then we'll have our next team on deck, which is Life Passport.
All right, good evening, everybody. My teammate is to share her screen while I present. All right, hi everyone. This is Team Life Passport, and we're made up of 3 people. I'm Deborah Onalo, someone who has pharmacy background, and with me is Somto. So I'll allow her to introduce herself.
Yeah, my name is Somto, and I am a tech developer, and I also work at a pharmacist called MedPlus in Nigeria. And with me is my team member, Toby and Deborah.
All right, so we'll just go straight. Please, can you go to the first slide? All right, so currently in our country, healthcare data is fragmented. You could walk into a pharmacy today and get medications, or you could get vaccinated and you don't have access to any of those records. All you know is, oh, I went to this pharmacy today and I got meds for my headache, or I was vaccinated when I was traveling for my trip to another country. And when I need these records at another time, I'm unable to provide them. So in immigration cases, when I move from my home country to another country, maybe for work or something, I end up spending more money trying to redo these tests, or I'm unable to present information about medications that I'm currently taking. And at the end of the day, this can lead to polypharmacy, misdiagnosis, amongst others. Please, next slide. Can we go to the next slide, please? All right. So we also have the issue of, broken records when it comes to, language barriers across various states in the country, saying that we have 36 states in our country. And basically, we just spend a lot of money trying to duplicate tests and, waste provider time in trying to cater to people's emergencies. Please can we go to the next slide? Next slide. I'm just going to go ahead and talk about our solution. So the solution we have built is Life Passports. So with Life Passports, we aim to sync healthcare data across hospitals, across patients, basically putting healthcare data in the patient's hands, so that no matter where you are, no matter the country that you are in, the emergency situation that you find yourself in, you're able to present healthcare data, and providers are able to, profess solutions tailored towards you. So I'm going to go ahead and show our prototype because we're in the prototype phase at the moment. All right, so with the use of generative AI, we're able to come up with this prototype that basically shows your key health metrics after visiting hospitals, and hospitals have the ability to data to life passports. Now, for patients, it's free, but for hospitals, they would pay. Sorry, for hospitals, they will pay a monthly fee of about 2,000 naira, which is about a dollar in my in when we convert it. And then for can you go to the profile section? Profile, please. We're running out of time. All right, so basically, and since I'm running out of time, I'm just going to summarize everything. Life Passport puts your healthcare data in your hands and allows you to present this data anywhere you are in the world. Yeah, basically that's. Thank you.
And we'll now begin the Q&A session.
Thank you for your presentation. Having worked in several healthcare systems, and from that, how are you going to be getting the data into your health passport?
All right, so there are two entry points to get data into the passports. We have the patient upload, and then we have where hospitals have access to upload customers and patients information. So after, say, I have done some lab tests and I have been able to get some medications, that information is already aggregated into the, let's say, EMR, and that can be shared with the customer if the customer is on Life Passport as well.
Gloria here. So I'm curious about the value to the customers. It seems that you mentioned the hospital will pay, not the inpatient. So what is the value to that pay customers, the hospitals? And also the second question is about the data interoperability. So I see a very nice dashboard prototype, but understanding each EMR in different hospitals, different countries may vary. So how do you make sure the data can talk to each other and can be presented in your dashboard?
All right, thanks. So I would start with the second question. We have tried to make our upload process as simple as possible. So can you please click on the upload button? You just tell us the type of data you want to upload, and you try to, you tell us data you want to upload, and then the type of data, and then you upload it in a simple way that the patient can understand, as well as if this data is presented to another healthcare provider, he can understand. It can be as simple as blood pressure per minute is 120/80. That's as simple as that. That way the patient can understand, and the healthcare provider in the next hospital or country can understand. Then the first question, we talked about why should the hospital pay. So the value proposition we're giving the hospital is you don't have to spend a lot of time that can be spent trying to cater to another patient, redoing tests, trying to figure out, oh, what could be wrong with this person, or maybe you've gone ahead to give medications and then the person is reacting in a particular way. You just get information about this customer and you're able to give the person personalized care that would ensure better therapeutic outcomes. I don't know if you heard me. I think lastly, I want to say that things will be, the EMRs and health passport would have API integrations, which will be able to, present or call data in the way that the EMRs would understand, and then the patient will understand.
Got it. Thank you very much.
All right, and if there are no other questions, we'll move on to our next team. So Team Masova, if you can start screen sharing, and we'll get started with your presentation shortly. Team Masova?
Sorry, I would want to add something that a lot of the data I presented could not be shown. So I've put my
Sorry,
presentation in the chat. So just that.
Okay, thank you. Sorry, we asked that once you've done your presentation, please refrain from coming off mute, just out of respect for future presenters. Thank you.
Sorry, I have a little bit. Please, I want to share my screen, but I'm unable to do that. Can you give me just a few minutes, please?
Yeah, sure. We can. Are you experiencing? Is it not allowing you to? Like it's not giving you permission to share, or you're just experiencing technical difficulties on your end?
Some technical difficulties on my laptop.
In that
sorry.
case, we can move on to the next team, and then we'll circle back to you if that's all right.
Yes.
Okay. Is Maisha maternity briefcase ready to go?
Yeah, we're ready to go. And while I'm sharing my screen, I'd like to invite my teammates to make sure that they're audible enough.
Hello.
Hello, can you hear me?
Yes.
Yeah, perfect.
All right.
All right.
Okay.
Again, thank
give me
you.
a second. Let me turn on my video. Okay. All right. Hi, my name is Caleb Kyoko. I study computer science from Kenya.
Hello, my name is Priscilla Oche, an electrical engineering student from Kenya too.
Hi, my name is Anemba Samantha, and I'm an MBCHP candidate from Uganda.
Now, today we are going to talk about something that we are deeply passionate about. But before that, we want you to meet someone, Faith, a 21-year-old refugee from the DRC who currently lives in Burundi. Now, if you know anything about these countries, is that they are currently under extreme violence and poverty. During her migration journey, while just 4 months pregnant, Faith had a miscarriage. This would not have happened if she had essential care when she needed it, especially in her pregnancy and delivery process. The ideal situation for women like Faith is to have the essential maternity care right when they need it, regardless of their migration status. This is not just a problem affecting Faith. On average, about 61% of global maternal deaths occur in regions affected by humanitarian and fragile conditions. This represents a pregnant woman dying every 2 minutes from pregnancy and child-related complications. The maternal healthcare crisis is huge. On average, a woman on the move is 3 times more likely to die as compared to a woman who is not on the move, and over 76% of births in crisis settings happen without a healthcare professional present. This points to a key barrier in accessing the right maternal care when it is needed, especially during the pregnancy and delivery process. This is why we are building the Maisha Maternity Briefcase. Maisha is a Swahili word which translates to life, and with the Maisha Maternity Briefcase, we are targeting women in their prenatal and delivery process, and our kit comes equipped with the right essentials to enable these mothers to attend to any emergencies during their pregnancy and also delivery process. On top of that, we have a trained offline AI midwife trained on essential maternal care data to attend to these women in case immediate help is not available and these mothers have access to our briefcase. So, Samantha, how does this work?
Thank you, Caleb. Maisha provides a solution or intervention at 2 critical points of a mother's pregnancy journey. That's at the prenatal stage, whereby it provides for fetal monitoring, as well as providing rapid diagnostic tools. And at the point of delivery, it helps with emergencies, any kinds of emergencies, as well as emergencies that occur immediately after delivery. Next slide, please. So Our primary focus is for the antenatal mothers, as earlier mentioned. These are mothers within the first, second, or third trimester. And we also look at mothers that are intrapartum. These are emergencies that occur during the process of delivery. And we also look at complications that happen within the first 24 to 48 hours. Our target population is mostly people who are in the vulnerable group of those who are displaced in displacement situations, those in refugee camps, as well as those in transit corridors. Next slide, please. So Maisha stands out. Maisha stands out as the only comprehensive AI-guided maternity solution that's portable and is friendly to non-professionals, as well as integrating healthcare systems, unlike the competition, whereby they only offer facility-based solutions that are only friendly to those that are professional users. Next slide, please. So our deployment plan is basically to integrate our solution within communities, and we plan to do that through local assemblies and local assembly hubs and local assembly partnerships. We also plan to have hospitals buy into our idea by, first of all, providing maintenance, training the users, as well as also being potential investors. We also plan to have NGO distributorship networks, so NGOs can partner with us. And our solution, we plan for our solution to be integrated within transit, for example, being a first aid kit on buses.
So how will we make money? You see how first aid kits are in buses. We also want to integrate our solution into the transit sector. Also in the East African community, there's been a lot of conversation between governments and NGOs to invest heavily into maternal care. And basically we want to tap into that through partnerships with these entities. In terms of our expenses, we want to focus on everything local in terms of manufacturing, assembly, and the distribution network. Also sustainability-wise, we'll be doing maintenance of our reused briefcases. So how will we measure our success? It's when women like Faith have 24/7 emergency support, and also when midwives have the necessary tools to do their jobs. And lastly, through Window AI, professionals are able to monitor the health records of the mothers, and we hope that this reduces preventable maternal and newborn deaths. So we ask for a total of 2,000 USD, and this 2,000 USD will go into the first phase of our project, which is launching and testing, and it will go into manufacturing 5 units and any associated costs. Our team comprises of emerging innovators like Caleb Kioko, who assists with software and AI engineering, Samantha, who is a medical student and has done some rotations in the maternity unit, and I, Priscilla Oche, an electrical engineer with sustainability experience. Our team of advisors that we've picked from our education or internship experiences have experience in maternal health to business development and have basically been guiding us through the development of our project. This brings us to the end of our presentation. If you have any questions, feel free to ask. Join us as we save mothers and newborns together. Thank you.
Thank you for the presentation. I have a question about whether you are providing any insights on the measured data and recommendations for next steps. So for example, you brought up Doppler devices, oximeters, things like that. Are you providing any of those things for that measured data, or just giving them the raw output there?
So one of our key differentiators is that we're actually working in partnership with the hospitals, but we are not, we want to make it clear that we are not replacing the hospitals themselves. So this means that with our briefcase, mothers who are in the migration journey can use it, and through the offline cards that we have to track, they can write any data there or even submit it to Window AI. And then we are collecting all that data and syncing it to healthcare facilities when these briefcases go for maintenance, or when an alert is given to these hospitals, and then they can arrange to have that data in the nearest pickup and maintenance point.
I see. Thank you.
Thank you for your presentation and working on this problem. My question is around implementation. How do you plan on training the users to use this and maintaining these kits?
Okay, I'll answer that question as well. So we plan on training users through community integration. So we go to communities and train these users on how to use this solution. And we also plan on training hospitals to train users as well. So we're going to use hospitals as that meeting point because, like Caleb said, we're not replacing hospitals, but we're basically providing an emergency toolkit, meaning it's like a first aid kit. After they use that, the mother can be taken to the nearest healthcare center. We just want to provide them with the next necessity that's needed within that emergency point. So even when you look at our users, we are meeting them at the point of need, whether they're at antenatal phase or whether they are during the process of delivery or even immediately after delivery, if they have any complications like postpartum hemorrhage or even antepartum hemorrhage for the cases of APH antenatally, we look at meeting them at that need. So we're going to train hospitals to train users, as well as also go to communities and train a number of people to use it.
And the same people will refurbish, maintain those kits.
Yeah, exactly. And also I'd like to add that where we come from in East Africa right now, if you go to any public transit vehicle, you'll see a first aid kit. And eventually training has reached workplaces and things like that, where the organizations in charge of that come in and train the populations. So we are aiming to go with a similar model where we approach training face by face until eventually everybody is familiar with our briefcase.
Can I jump in with one quick question? This is Archana from Gates. Are the devices going to be IoT enabled? So for instance, if you identify a high risk case, like you said, you want to flag it maybe for an emergency admission in a secondary care clinic, but you identify this on a bus, what happens then?
Yeah. So essentially, our devices come in the form that the simplest form that we can fit into the briefcase. But on top of that, they are tech enabled in the sense that makes sense the most, since our briefcase is mostly offline capability. But with the Endo AI offline device, we are able to take all that data and then sync it to the necessary systems on the cloud, and then with our team on the back end, we are able to process that and answer to any queries that need the technical human connection.
Very interesting. Good luck.
Thank you.
All right. Thank you so
Thank
much.
you.
So next, we'd like to circle back and see if Masova is available. If not, we'll move on to Ethio Health Tech.
Yes, we are ready.
And you're with Masova, is that correct?
Yeah.
Okay, perfect.
Can you see my screen?
Yes.
Yeah.
Okay, and you can begin.
Yeah. Hello, everyone. I'm Yunan, and I'm from Madagascar. As a young mother, I experienced a difficult emergency C-section with my two babies, an ordeal that led me to discover the depth of maternal health challenge, mostly during crises like today in Madagascar. Today, many major maternity wards in Madagascar have declared zero service, a status to strike systemic collapse in the country. And this means that vulnerable mothers are being turned away from hospitals and forced to give birth at home with untrained help. The devastating result is a single maternity ward recorded a shocking 500 maternal deaths last year. The problem is no longer just a lack of beds, it's a fatal delayed decision-making where mothers arrive too late for an emergency care because they lack early information and proper risk detection. Mostly concern majority of migrant people within Madagascar who are forced to move due to natural disaster, insecurity, food scarcity, or poor healthcare access in their area. So our answer is maternal AI, which is a digital ecosystem that closes the life-threatening gap between the mother and care. At our core is a mobile application powered by predictive artificial intelligence, which monitors the entire pregnancy, detects danger signs using electronic health record, and alerts professionals in real time about missed consultation or critical symptoms like severe anemia or fever during an outbreak. To ensure inclusion where connectivity is limited, internet connectivity is limited, the app is a multilingual Malagasy, French, English, and crucially function on basic feature phone like SMS and USSD. So the market is huge. Madagascar has 2 million women of childbearing age, and they perfectly align with the country's national digital health strategy, where our competitors are indirect players like NGOs, our basic social group, in international and national competitors. Our key competitive advantage is our digital model that integrates AI-validated follow-up, USSD accessibility, and the localized revenue-generating marketplace. Our financial sustainability is secured through a robust triple-pillar hybrid model. First, a reliable monthly recurring revenue comes from individual subscription, made accessible via mobile money. Second, stable funding is secured through B2B institutional contract with corporation and NGOs, which purchase service packages for their employees and vulnerable communities. To scale our impact, we rely on strategic partnership. We are working with UNFPA to validate our data impact, and IGM Medical to ensure our clinical protocols are validated and referred health professional are certified. We are a 4 multidisciplinary team behind. Me, I'm the founder, majority in digital humanities. I have 2 computer engineering and data science developer and a mobile app developer. Our go-to-market strategy and to collaborate with NGOs. We're focusing on pregnant women first in first trimester of pregnancy. And our 12-month roadmap is focused on rapid scaling and self-sufficiency, reaching 1,500 active paying users. And our most critical financial milestone is securing $15,000 to cover our charges and to achieve the operational break-even point by the end of 2026. We aim to reach 1,000 women paying. And maternal AI is not just a health app, it's an investment in life and empowerment for young mothers. So if you want to join us, we're so glad to have you. Thank you so much.
And we can do the Q&A now.
Thank you for the presentation. I had one just clarification question. I think there was a slide that said it was a combined physical and digital solution. Could you clarify what the physical component of the solution is?
Yes, so about a physical solution, right now, because I'm the beneficiary of Africa's SHDC program within being Huawei Health, so I'm implementing the solution in Madagascar, which aim to mobilize and raise awareness on the importance of doing prenatal visits, because Madagascar people ignore the risks during pregnancy. There is just 30% of women who reach the 8 recommended prenatal visits, and it is really dangerous for the women. So we are launching campaign, raising awareness, and doing some workshop, event, and webinars to teach people how to reach local healthcare providers and prevent them to make dumb decision, which is very riskful for their health and their babies.
So my understanding of your business is that you're dependent upon user fees, is that right? And so if that's the case, have you thought about just willingness of the users to pay?
No, first, our model is B2C, which is about a subscription, but there is also a marketplace within, because we chose marketplace because it is sustainable for us. In Madagascar, there is a high increase in demand of sellers of babies items and mommy's items. They are reaching out to us and ask us if we can develop a marketplace within the solution so that they can put the items in the marketplace. And there is also a partnership with local NGOs and corporate, so they can pay on behalf of the women.
You mentioned, and congratulations on your achieved milestones. Can you talk a little bit more about that? Like how many people have used it, what results have come to date, or any strategic partnerships?
Okay. This year on May 2025, I was accepted within the Africa SHDC program. After this program, I decided to gather some competent people in my team. We just developed a prototype, so that's why I'm participating in SHDC. And actually, we're of ongoing partnership with IGM Medical and UNFP Madagascar. And we are supported by Africa SHDC, African Union GIZ, and UFOB Africa.
Thank you.
Thank you so much.
All right, thank you so much. Next up, we have Ethio Health Tech. By the way, we're looking at your screen as vertical, so the slide is very small. If you're able to move I assume you're on a phone. If you can move it horizontally, that might help. Oh, perfect. Thank you. And are you ready to begin? We can't hear you right now, by the way.
Okay, may I start?
Yes, go ahead. Thank you.
Okay, thank you. We are at your holistic. The team Muhammad Ziku, Zareen Huluk, and Shamsuddin Abdi. We are from Ethiopia, and as a team, we are working on detecting the ammonia level to analyze the performance of kidney. As a problem, our team is identifying the problem by visiting different hospital, clinic. So chronic kidney disease is spreading over the world with an estimate range from 8 to 60%. So patient with an end-stage kidney disease need renal replacement therapy. So I meant that. So the problem that we identify is expensive testing procedure when people want to check their kidney status, and it's time taking, and it's minimally invasive way of checking. They take your blood by pinching your fingertip. So not having routine checkup or the habit of checking their kidney status is the problem that we identify. So regarding the solution, we use breathe ammonia as a biomarker to provide fast, non-invasive detection of kidney function. As you can see from the picture, it's a kind of a mock-up prototype, so product or the service. The device takes a sample from the user and analyzes the ammonia level in the breathe sample. So our solution is totally non-invasive way of checking. User can have regular checkup with the design device. User will be able to examine breathe ammonia level and monitor kidney health at home. And we integrate a mobile application with our instrument, so people who can have a longitudinal follow-up. So here is the technology. Here is some pictures that we try to show for you. The first one is a fast detection. We use a a sensor that detects the ammonia level from the breed sample. We just try to use a low price because we are using locally available material and it's a home use, have some kind of mobile application that used for people to well aware about how they check their kidney status. We have integrated mobile application for fast notification. Regarding the market, we have a huge market opportunity because it's a new and innovative work. Everyone needs a kidney checkup regularly. So when we see the size of the market, we have many opportunity. Home user, hospital, health center, clinics, and other health institutions have our customers. So growth potential, we try to design the device with universal design, variety of product for different age, gender, and geographical location. Regarding the segmentation, the team focus on the home user and the refugees to facilitate awareness for personalized treatment. So regarding the business model, we are participating in regional, national, and international research grant opportunity to get funding. We have a cost structure, we have a capital investment in production, products, logistic, hardware, and software development, and contract manufacturing. Pricing strategy, we have a website for online selling, physical store for face-to-face dealing, and social media for promotion, and revenue stream, direct selling the developed product to our customers, subscription fee for the web-based mobile application, and consultation and training fee for if the user need that. Here is our competitor. Our developed device competitor are other clinical medical device and the traditional checking method. So when we try to compare with the clinical device and traditional method, we have a feature, time efficient, non-invasive, longitudinal tracking, and personalized checking. So our design is superior than the other. So we have a breakthrough for the market area. And here is our team, Mohammed, the Chief Executive Officer, with background is biomedical engineering. He have a master's degree in biomedical instrumentation and imaging. The Chief Technical Officer is Zarhyun Huluka. He is a biomedical engineering professional. He have a BSc degree. And the Chief Financial Officer is Shamsuddin Abdi. His background is electrical and computer engineering. Now he's a student. Regarding our financial model, we, as ETO Holistic, we need $20,000 USD for a self-funded to complete this product development and launch. Currently, we win 1,500 USD from Armar Hansen Research Institution in collaboration with the Ministry of Health Ethiopia, and we're working to get another fund because the fund is in a different stage. So regarding our milestone, by December 2025, we will develop the prototype and minimum valuable product. By February 2026, we will work on the scale up and meet legal requirement. By March 2026, we will develop the product, carry out clinical testing, validate the product. And July 2026, we will directly selling the product and doing post-market surveillance. Thank you.
All right, and we can move on to our Q&A session. Thank you.
Were you able to talk to any clinicians or possible patients on their interest and use?
I'm sorry, would you mind if you repeat?
Were you able to talk to any clinicians or patients regarding their interest in using it?
Okay, yeah, thank you. I'm working in the University of Gondar, so I have a direct attachment with the university hospital. So we were there and communicating with the different patients and different clinicians in the dialysis room. So we communicate with them.
This is Gloria here. If I understand correctly, you are at the ideation stage. I saw in your timeline you haven't had a prototype or MVP yet. So understanding ammonia could be a promising biomarker, but based on research and other evidence, do you know what is the false positive, false negative rate for using ammonia to diagnose kidney disease? And also, why have other healthcare professionals not have pursued this route to use it as a detection method as yet?
Okay, thank you. If I got your question, we are using ammonia for detection of the kidney status. So we try to search different kind of researches. So we got a concrete research that dictates the level of ammonia in a breath increase when there is a problem in the kidney status. So there is a level. There is many cases to increase the ammonia. For example, if somebody drink, the level of ammonia will increase in his breath. And if somebody have a problem in a teeth problem, so there may be increase in ammonia level in the breath. So we differentiate this. So if somebody have a kidney problem, so there is an increase or elevated level of ammonia in his breath. So that's why we want to detect the status from the ammonia as a biomarker. So there are some researchers under research, not in a working device, but they are under research. They use volatile compound to detect such a kind of some other biomarker. So specifically, we select ammonia because the elevated level of ammonia in the breath directly related with the kidney status. Thank you.
All right, thank you. And our last team will be Amani. So if Team Amani can hop off mute and start sharing your screen.
All right, let me get this started.
And let me know if any of your team members are still experiencing difficulty.
All right. Let's see. Can everyone see my screen all right?
Yes.
Yes.
All right, perfect.
All right.
Okay, so our team is called Amani, and my name is Alish Bansari.
My name is Lena.
I'm Roshan Khan.
And I'm Ian Ansari.
I'm Hina Khan. In refugee and migrant settings, communicable diseases are a leading driver of preventable deaths. These are fueled by environmental hazards such as contaminated water, open sewage, and inadequate sanitation. However, the devastating part is that when these hazards emerge, it takes over 72 hours just to report them. So by then, what could have been just contained in hours has become an outbreak costing hundreds of lives. So we aim to solve this gap between when a hazard emerges and when help arrives to help prevent even more unnecessary deaths. You need to unmute.
To put this into perspective, in recent years, Baqa, a refugee camp in Jordan, experienced a sewage leak that went unchecked for over 5 days. By the time support from aid workers had arrived, dozens of children had already begun displaced. Residents of the refugee camp lacked the proper channels to communicate and escalate the hazard, a solution that could have saved the camp from a dangerous outbreak.
So essentially, our solution is Amani. It's a tool that lets people in refugee camps report things like sewage leaks or unsafe water right away. Instead of waiting for NGOs to find out, Amani sends the information straight to response teams in real time. So this means that problems can be fixed within hours instead of days, which could literally stop outbreaks before they even begin.
Here's how it works. So what makes Amani powerful is that it's innovative but completely feasible with the technology we already have today. It's built to maximize output for migrant and displaced communities, helping them share accurate and verified information that directly supports faster public health responses. So here's how it works. Users capture a photo or video of a local hazard, something simple and familiar. The app then helps them add short notes or voice recordings while automatically filling in key details like location and time. These are features every smartphone already supports, which makes the process highly practical and feasible. Next, Amani uses lightweight AI verification to check for duplicates and identify hazard types, ensuring the information that reaches responders is clean and reliable. Once the data is uploaded, it's analyzed and routed to the right health or humanitarian teams, cutting delays and improving early intervention. So the innovation here isn't about building something complex, is about using existing feasible technology in a smarter way that maximizes the real impact for the people who need it most.
So systems of mapping wash hazards in migrant communities simply just doesn't exist. Amani itself here is the innovation. Not only does it introduce a mapping system for inadequate wash sources, it does it in a clear and efficient manner that can be easily picked up by anyone who's using it. It provides agencies to communities that have lost agency. With Amani, they're able to advocate for themselves by making wash hazards known to all members and of an affected community and decreasing the response time. And paired with this, you have the introduction of AR assisted mapping from ordinary phone video. So not only are you able to provide more detail than a traditional 2D mapping system would, you're able to simply pan your camera around and Amani will tell you what clean water sources are nearby and which ones are unsafe. And so with this, we plan on having 5 deliverables at the moment. Our main cost would come from the app and backend development along with the cloud and security infrastructure, because that we would be developing the majority of this ourselves. However, a lot of the AR technologies is open source, and we would be building off of that. From then, we'd field pilot and partner with local NGOs. We currently are in contact with Ficus Nostalgus, which is an organization that works, or FISEC Nogales, that works close to the border for helping migrant communities. Then we move on to control testing and refinement, and then lastly, we'd focus on training and community outreach. Thank you.
All right, and we can move on to the Q&A.
I have a question. Who will be the key users of this tool?
So the users we plan on having are the actual refugee residents, along with aid workers that exist there. So it would be the entire idea of this is that it's a community-based approach. So you have both residents there who basically notice water hazards there, wash hazards there, and along with any aid worker that happens to notice any of them.
And just adding to that question, who would be the key purchaser paying for the app?
So we'd be working alongside with many NGOs that would incorporate this with a lot of the works that they already do. So one of the ones that we're looking at right now is Telecom Sans Frontiers, which works with a lot of like migrant communities and refugees that currently don't have any that don't have a lot of access to technology, but a lot of them do have like water inadequacies, as well as in some cases already a pre-existing internet infrastructure.
When you're doing user research or when you are talking to these experts from the NGO, etc., how did they compare your solution, which is a high-tech solution with AR, etc., to the existing, I would call it low-tech solution, maybe just like pick up the phone and tell some experts about the water leakage. How did they compare the two approaches?
One thing I'd like to reiterate, although you may call this a high-tech solution, we'd like to reiterate that what we're using is nothing completely innovative. We're just using what is the common technology today, and we're using it in a way that's more reliable for our project. Another thing that we would like to focus on is there are no more time delays because of the old technology. There would be constant time delays. There would be losses of information. However, with our new program, those time delays are all cut out, and we minimize lost input and maximize output.
Thank you.
Maybe this is more of a suggestion. Can you elaborate a little bit more on like why does it take 72 hours right now to report communicable diseases, and how would like your solution actually address that? The key barriers, I think I'm not very sure.
So to give you guys an example, say there's a woman with a sick kid in a village. It's essentially a game of telephone. She has her sick kid. She reports it to, let's say, authorities in a camp. Then from there on, it's a voice of telephone. It gets lost with human error. People obviously don't address everything right away, so it's a waiting process. However, this new program, it connects the people in the camps. It connects the people in the camps straight to the people who can help them out, and so it minimizes the outbreak, because in that 72 hours, the outbreak just constantly increases without any help.
All right, thank you. And if there are no other questions, we'll now conclude our presentations. Thank you so much to all the teams who have presented. I know this is the culmination of a lot of hard work, and we really are grateful to you for spending the time to present to your ideas and really refine over the last 2 weeks your solutions. I'm going to briefly describe what will happen next, and then I'll hand it off to my team to take over during the deliberation portion. But basically what we'll do is we'll have the judges break out into a separate Zoom room. Judges, I've sent you a direct message on this Zoom chat, so please check that. And if you have any trouble accessing that, let me know while we're still here. And then once we've hopped into that Zoom room, my team will take over. We'll do a brief spotlight of all of our judges, so you have more of a context of who our esteemed judging panel is, as well as a highlight of all of our sponsors and partners without whom this wouldn't have been possible. And if there's anything else from my team, otherwise I'll let them take it away. And judges, please join the breakout room, or not the breakout room, but the separate Zoom room now. So you'll be moved to a different Zoom, and then you'll rejoin this original one once we're done.
Okay, great. Great job, all the teams. I'm going to go ahead and share my screen. So for a little bit of transparency on how we evaluate all the teams, we're focusing on 5 main areas. 1 is understanding the problem. 2 is solution value. 3 is the feasibility of implementation. 4 is the overall presentation. And 5 is product differentiation. So we have 8 judges. Renee Cassie was not able to join, so we'll have 7 judges who are evaluating all of the presentations. First, we have Dr. Amanda Ma-Chung. Amanda Ma-Chung is the executive director at the Stanford Center for Innovation in Global Health. She has over 20 years of experience in global health, primarily in academia and nonprofit organizations. At UCSF, Amanda was the PI on a Gates Foundation funded project to integrate Zimbabwe's male circumcision services into the HIV prevention program. She also co-developed a leadership and management framework that has been used by the frontline workers in Eswatini and Zimbabwe, and is now being rolled out in Cameroon. Amanda's experience spans the areas of immunizations, maternal, newborn, and child health, HIV, eye health, and malaria in Africa, Asia, and Latin America. Amanda holds a PhD from UC Berkeley and an MPH in community-oriented public health practice from the University of Washington and an AB in ecology and evolutionary biology from Princeton. Dr. Gloria Tam is a faculty member at Harvard University's Division of Continuing Education, where she teaches in the Digital Media Design program, and is a professor at Minerva University, where she teaches product development and needs identification at the College of Business. She's a former consultant with the World Health Organization and McKinsey & Company. During her time with the World Health Organization, she supported the launch of the WHO Academy, a global learning institution with the mission to upskill over 10 million healthcare workers worldwide through innovative technology-enabled education. At McKinsey, she worked extensively on healthcare companies and public health systems, advising health systems on disease crisis response and health financing reforms. She collaborated with academic medical centers on operational transformation and advised the Bill and Melinda Gates Foundation and leading pharmaceutical companies on strategy and organizational design. Her work bridges learning innovation, healthcare strategy, and organizational transformation. Archana Srivastavan is currently a partner and strategic investor in the USD $2.5 billion corporate venture arm of the Gates Foundation. She leads corp dev and VC investments in early stage and growth stage for profit companies and drives portfolio growth. She focuses on fintech, health tech, and climate across consumer and B2B models. She was named in the 2024 Power List of top 100 corporate venture leaders globally. Beyond the day job, Archana mentors tech startups in the UK and South Asia. She's a non-executive director in a top 20 UK charity and a board member in multiple Series B plus companies in India. Faye Sahai is the managing partner of Telocity Ventures, investing in digital wellness and mental health startups. As an investor, innovation advisor, and inclusive change agent, she applies her 20-plus years of experience to invest in startups and advise companies in innovative and inclusive strategies to drive transformation for companies, including AIG, Schwab, Deloitte Consulting, Blue Shield, and Kaiser Permanente, and has co-founded 3 startups. Moreover, she has launched the AIG Global Innovation Center and managed the innovation and digital business. She also managed the Kaiser Permanente Innovation Lab and Fund for Technology. Faye Sahai has been recognized with the Elite Woman Award as one of the IBA Hot 100 leaders and Computer World Top 100 Premier IT leaders. Dr. Jason Cunningham is the Chief Executive Officer at West County Health Centers, a federally qualified health center caring for patients in Western Sonoma County. He previously served as West County Health Center's medical director. He's a family physician and remains dedicated to patient care. Additionally, he is the program director of the Stanford School of Medicine's Clinical Excellence Research Center. Peng Wang leads the community and campus relations at StartX, a community and accelerator for Stanford founders with healthcare as one of its strongest verticals. She works with thousands of Stanford founders, mentors, and investors to build the vibrant entrepreneurial ecosystems at Stanford. Before joining StartX, Peng worked across the healthcare and medtech sectors, advancing innovations in heart and brain health at Pfizer, investing in digital health early-stage startups, and translating cutting-edge science into real-world impact at Stanford's Office of Technology Licensing. And last but not least, Lauren Menser is an algorithms research scientist at Analog Devices Innovation Lab, Analog Garage, who is passionate about healthcare innovation and uncovering unmet needs within healthcare workflows that technology can address. She started her career working on robot perception algorithms and made her transition over to healthcare projects in 2024. So we're very excited to have such an esteemed group of judges who will be evaluating all of your pitches today. And I want to remind teams of our prizes. Our grand prize winner gets $2,000, our runner-up gets $1,000, and we also have an analog devices best use case for $500, which we'll talk more about in just a bit. And I'll pass it off to Bharat for our spotlights.
It's truly my honor to thank all those partners and supporters of SHDC, Analog, Stanford School of Medicine, the Knight Hennessy. Special shout out to Knight Hennessy. SHDC was born out of Knight Hennessy Scholarship Program 4 years ago. We're endlessly grateful to their mentorship, network, and support. We host all our board meetings at the Denning House. So thank you so much, Knight Hennessy. Next slide. We also want to thank Stanford Medicine Clinical Excellence Research Center. They're one of the first university-based centers in the United States whose research and education programs are exclusively dedicated to rapidly advancing cost-saving innovation across engineering, medicine, and management. And next, we have StartX, which is the premier community and accelerator for Stanford founders, offering support without requiring any equity. And I want to introduce you to Britta from Analog. Take it away.
Wonderful. Thank you so much. Good morning, afternoon, depending where you are. I'm based in Boston, so I guess for me it's already afternoon. I'm Berta Martí-Fuste. I'm the Innovation Lead of Health Sciences and Analog Devices. Let me see if I can quickly share my screen so you can learn more about what we do, who we are. Let me see, 1 second. Here you are. Share a screen. Oh, okay. 1 second. Security.
Is it not letting you share your screen?
Not yet. So let me see if I can do it now.
Okay, we got it.
See it now. Okay, wonderful. So sorry, like we have a lot of like IT security barriers in the company and it's popping up here. So as I was saying, I'm part of Analog Devices. It's an honor here to be here today representing the company and our innovation lab, Analog Garage. For those not familiar with analog devices, or what we call it ADI, we're a global leader in combining analog, digital, and software technologies to solve real-world challenges. With a market cap of like $110 billion and an annual revenue around like close to $10 billion, hopefully this year, we're driving innovation across industries, from automotive and energy to healthcare and industrial automation. Our mission is simple. We create solutions that improve lives and the world. And in healthcare in particular, that means enabling smarter diagnostics, personalized treatments, and connected care. For over 6 decades, ADI has grown to offer more than 75,000 products, serve 125,000 customers, and build a global team of 26,000 people around the world. Our technologies span analog and mixed signal, power management solutions, RF and microwave, edge processors, and AI and machine learning, of course, all designed to turn like signals into actionable insights. And today we're actually like investing even more on R&D and manufacturing to actually shape what's next in the company. We build the intelligent edge where sensing, measuring, computing, connecting, and powering all actually come together to connect the physical with the digital world. Particularly in healthcare, ADI is at the forefront of the transformative ecosystem. We help our partners and customers move from reactive to predictive care by integrating analog, digital, and software in easy-to-use solutions. That's our main goal in healthcare. And whether it's a wearable, a remote monitoring, or a diagnostics, like our technologies help to bridge the gap between like the body signals and the meaningful insights that you can get from those. But as they mentioned, like both Lauren Mentor, who is now today like as a judge panel, and myself, we are part of like a sister organization within the big company called Analog Garage, which is our own innovation lab. And at Analog Garage, we are actually like pioneering breakthrough technologies that could nurture billion-dollar ideas. We combine agility and stability, building on the solid foundation of ADI's 60 years legacy at the forefront of cutting-edge technologies. We are a fast-moving, idea-driven startup atmosphere fueled by engineers, data scientists, and more. And as I said here, we like the main focus is to conceive and nurture like transformational ideas that help us advance the art of possible in order to solve the world's toughest challenges and enable actually ADI's current and future customers. At Analog Garage, our focus, I said like the company, the scope of the company is pretty broad, but here at the Garage, we focus mainly on 3 pillars, like health of human is one of them, health of planet, and then autonomy and intelligence. And these are the guides, these 3 main pillars guide our venture funnel and the innovation process that we have internally to create these disruptive technologies. So at the Garage, at ADI, but also at the Garage, we believe that innovation starts with people, and that's why we are very proud of our teams who span like from algorithmic solutions, deep tech innovation, platform and system engineering, and also like business strategy and all the operations that we need. So we work together in a very multidisciplinary environment to bring innovation solutions for all. Our venture funnel, or the way we populate our portfolio of projects, is structured on a process that moves ideas to prototypes and to prototype to scalable businesses. And each of these phases has a gate, so we can ensure the right focus and resources at every step of the journey. So then we can support ideas that we can truly change lives, just the ones that you just showcase and highlight today, which is pretty exciting. And we hope that, with this quick overview of who is ADI and what we do at the Garage, you can have a better picture on who we are and why we're excited to support this Stanford Healthcare Challenge this year. As part of that commitment, as it was said, like we're proud to be the sponsors of the Best Use Case Prize, like that will recognize the team whose solution best captures and processes body signals for personalized value-based care. But beyond today's competition, we believe innovation thrives through collaboration. So if you are passionate about shaping the future of healthcare, we would love to connect. Either you are a student, a researcher, or an entrepreneur, we truly believe that tough challenges can only be solved together. So with that, thank you and all the best to all the teams.
Thank you so much. We're very honored and proud to be partners with you. So while the judges decide on the winners, I was asked to show you our website. So this website is brand new. It's our first year having a proper website. I just wanted to walk you through it, show you what we've done so far. I first want to start with our launch video. This was the video we launched at the beginning.
In 2024, we launched the first ever Stanford Healthcare Design Challenge with one goal: to improve access to and the quality of healthcare. This year, we're going global. We welcome any student from any university, anywhere. By the end of 2024, over 120 million people were forcibly displaced due to conflict, violence, and human rights violations. It's time to reimagine healthcare for those who need it the most. This is your chance to tackle this year's Global Health Challenge. Design a scalable healthcare solution that addresses the needs of a population experiencing geographic transitions within a domestic or international context. Please join us over Zoom for our September Learning Series to hear from experts in the field, from financial storytelling to humanitarian medicine. Applications launch today and are due September 22nd. Please see our website for more details.
Yep, this was the timeline, and today is the demo day, our final day. Again, this is everyone that helped contribute for the 2025 challenge. This is where we showcased all the teams, and soon we will putting the winners on our website as well. Like we said, there's going to be 3 prizes: $2,000, $1,000, and $500. We had a calendar. And all of our learning series were recorded. You can still watch them if you're still interested. And yep, you can learn more about analog as well.
I see we have a question,
Oh,
or maybe that was a mistake. Oh, go ahead.
okay. Go ahead.
Thank you. So winner will have occasion to go to your campus to learn more for boot camps or something like that, further opportunities. Thank you.
Yeah, everything about our challenge is virtual since we're trying to reach people from all over the world. If you do stop by campus, we would love to show you around, but the challenge itself is all online and remote.
Yeah, we'd love to give you a tour if you're on campus though.
Thank you.
This was last year's challenge. We had an amazing cohort, and this was our impact report. If you want to take a look at that. And this was our winning team. I believe we're gonna have the winning team speak today. I'm not sure, Richa.
No.
Okay. Uh, and yep, do you want to talk more about recruitment?
Yeah, so before we end, I also want to talk about SHDC recruitment. Since SHDC was born out of Stanford's Knight Hennessy Scholarship Program, our executive team has grown immensely in order to support these global efforts. Every year, we're adding new people to the team, just because we're adding more things to the challenge itself. So as we close our 2025 SHDC year, we're looking forward to growing even more for 2026. Which means we're also looking for folks to join our leadership team. If you're interested or passionate about helping us run the challenge, we would love to have you join. What this looks like is spending time exploring healthcare trends to form a timely and high impact prompt. So we spent many weeks deciding that we wanted to focus on migrant and displaced populations this year, and we will do that same process next year to figure out what healthcare is looking like in the future. We also helped design the September Learning Series, finding people who were wanted to talk about their subject matter expertise, and then also get the word out for people to apply. So however you found out about us, whether it was through the emails we were sending, just searching us up on Google, or through LinkedIn, we want to keep on continuing that so we can get as many people as we can involved. We hold our recruitment and will share our application form on the website early next year and into the spring. So if you have any questions about recruitment, please send us an email and we would love to have you. So right now, that is all we have. I've gotten word from the judges that they're close to finishing. So we will just take a break and then we'll come back once they are finished. So thank you so much for being patient. And great job again, everyone. Just to answer the questions in the chat, you do not have to be a Stanford student to help us organize in the coming years. Open to, yes, master's and PhD students. Any person who is matriculated at an institution can help be part of the executive team. And you can email us at stanford.hdc@gmail.com. I would say so the question was, what is the time commitment? We do meet about once a week starting during the summer because that's when we start prepping for our competition and the September Learning Series. And we have our recruitment in the spring. So from spring to then this October time, we're pretty busy with once a week meetings. After the challenge, immediately we take a break where we offer support to the winners for about 3 months, and then we start again in the next year. And depending on time zones, we can always work out a meeting schedule that works for everybody. I've been told that the judges are making their final comments, so we'll start the ceremony super soon. Thank you again. And also, after the winners are announced, I'd love to have the winners stay on just for a couple of seconds for group pictures.
All righty. Thank you all so much. We have our judges back in the room, so let me go ahead and share my screen. All right. Are you all able to see me now? See my screen?
Yeah.
Okay, perfect. Thank you. So we'd like to welcome back our judges. We had a very good conversation, good deliberation. They were super impressed with all of our teams. I think that this is a testament to how much hard work you all have put into this. And the SHDC team is super proud of all that you've accomplished. And it's been a really wonderful opportunity for us to get to know you and to really see you develop as innovators. Just before we announce our winners, we're going to go through what's next. So our winners are going to receive post-competition support to help turn their ideas into reality. And then all of the surveys that our competitors have been getting and that all of our attendees will receive after the conclusion of this webinar, that's feeding into our impact report. So we really appreciate you bearing with us as we kind of had several rounds of surveys. But that's really helpful for us to know what kind of impact we're having and to see what we can do to improve our educational offerings. Please follow us on LinkedIn. We have the QR code up on the screen, and feel free to visit our website, which is shdc.stanford.edu. And if you're interested in joining our organizing team, please send us an email. We are looking for enthusiastic people to get involved. So feel free to get involved in our team, and you can find our email on our website as well. So next, we'd like to move on to presentation of the winners. And we'll start with the analog devices best use case winner. So again, this is awarded to the team that combines analog, digital, or hardware or software solutions to best capture and process body signals, turning them into actionable insights for personalized value-based care. So Lauren, if you want to hop on.
Right. Hello, everyone. My name is Lauren. I'm from Analog Devices, and I'm very excited to announce the winner for this award. We are going to be giving this award to the MISHA Maternity Briefcase team. We are very excited about what the team has come up with. There's a handful of aspects of their solution, including a variety of essential checkup tools, which include fetal Doppler devices for heart rate monitoring, malaria screening, portable oximeters for vital signs monitoring, a lot of things that are very important. And the team had a great vision for the impact they could have on maternal care with their solution. So great job to the team. Very excited.
All right, thank you so much, Lauren. And next we'll have our presentation for our runner-up prize, who will be awarded $1,000 as well as receive follow-up support from our team.
And the runner-up is Maisha Paternity Briefcase as well, for its scalability, its uses, its thoughts, its presentation, kind of from that depth and kind of standpoint. And congratulations. Amanda, you had another point. Have your hand up?
No, sorry, I just did not.
Okay. But congratulations to Maisha Attorney Briefcase.
All right, thank you so much. And then now to announce our grand prize winner.
All right, I have the honor to announce the grand prize winner with the drum roll. It is Team Operation Innovation who presented the solution of walkie. We think this team has a very accurate problem you're prototyping for, which is the language barriers in UK healthcare settings for immigrant patients. And we think your team demonstrated very strong understanding of that health system complexity. How does NHS operates, how does a patient, what are the pain points? I think one of our judge, Faye, works at Kaiser, and she also mentioned she actually looked at a number of point of care solution on solution for translation, and she sees this as a really unique solution. The features that you're presenting. Some of the other judges also mentioned that integration with EHL, that you have thought about it, and it's very compelling. I personally also have a little story, and that's why I'm presenting this award. My dad just came from NHS hospital in Cambridge, UK, and he's actually one of the immigrant, like from Hong Kong. They emigrated to Cambridge, and basically he was waiting for heart pacemaker surgery, and he has to wait like almost like 3 weeks just because of the lack of translator. They kept rescheduling the surgery for like 5 times or 6 times. So this is not just a quality translation problem, it's also wait time, is also that frustration, that empathy for patients. So thank you for addressing that pain point. Thank you. Great job.
All right, thank you so much to all of our winners, and congratulations to all teams who participated. This is such a testament to your enthusiasm for innovation and your desire to really make an impact on the world. We're super excited for our winners. Please stay behind for some pictures. We're going to try to get this done on Zoom, so please bear with us as we figure out how to do this, but we'll ask that you turn on your video and pose for a picture with the kind of background of your announcement. Thanks so much to everyone who attended. Please fill out the survey so we know what you liked, what we can improve on. And thank you so much for spending your time with us today. It's been a pleasure having you. Thanks so much.
Ishan, can you stop sharing your screen?
Yeah.
Okay, let's do Maisha first. So maybe everyone who's Maisha, keep your cameras on. Everyone else, turn your cameras off. We'll do a team photo with them and the judges.
So unfortunately, one of our team members had a medical emergency, so she couldn't make it. So we're only two of us.
Okay,
Yeah.
hoping for a speedy recovery. I'm so sorry to hear that. And no worries, we can do an abbreviated photo. Okay, I can take it. Okay, everyone smile. 1, 2, 3. Hold on, hold it. Okay, got it. We'll do the same thing with Operation Innovation. So Maisha, camera's off. Okay, perfect. And 1, 2, 3, smile. Hold it, hold it, hold it. Okay, great. Thank you so much. And maybe we can do like both teams with the judges since we have everyone here.
Yeah, and let's also
I think we should do one with everyone too.
Yeah.
Yes.
All right, so if both Maisha and Operation Innovation, if you want to turn on your videos, and then we'll do one with everyone after that.
Okay. And 1, 2, 3. Got it. And then let's do everybody.
All right, so if you're in the Zoom room now still, please feel free to turn your video on. And then after this, I'd like to do one with the backdrop of just the team and with the announcement as well, so you guys have that for the future as well.
Okay. 1, 2, 3. Perfect.
Right.
Got
So
that one.
let me start up my share screen again, and then Maisha, if you want to, okay, we can do one of each. Let me turn off my video. So this one will just be Maisha. So if your judge or mentor or other team, if you want to turn off your video, and then Maisha, turn your video on, and Richa, you'll take this. So just make sure you see
Yeah.
everyone.
All right. Big smiles.
Oh, wait. Do we want to turn off all judge and non-Maisha team videos? All right.
Okay. And 1, 2, 3. Got
Okay.
it.
Let me get the runner-up one as well, so you have that too. Oh, wait. Do we want to redo that? I think someone else might have been in that too. Sorry. Okay, go ahead.
Okay, hold on. Oops. Okay. And 1, 2, 3, smile. Got it.
All right, and the runner-up now. So same thing, Maisha, stay on.
All right, and smile. Got it.
All right, and then Operation Innovation, if you guys want to turn yours on, and Maisha, if you want to turn your cameras off. All right.
And 1, 2, 3, smile. Got it.
All right, perfect. And I think that's all we have. Thanks so much to everyone who attended. Thanks so much to our judges, to our sponsors, our partners. You guys have been amazing, and we really appreciate you spending the time today. Congratulations to everyone.
We will
Jason, raise
upload
your
the
hand.
recording and photos to the website, so everyone will have them soon.
Yeah.
I was trying to clap. Good job, everyone. Thank you so much.
Yeah, thank you.